And then there you go.
Yeah, thank you so much for that. Thank you. Well, thank you everyone for coming to see Lady Parts on a Monday night. We really appreciate it. And thank you, Jillian, that was beautiful. Thank you for everything you said and all the policies you're pushing forward. You know, I know this is raising awareness, but making change is also, you know, we're all working together in this and there's so many components. So we're gonna just answer a few questions and we'll open it up for a panel Q&A after. So feel free to move closer if you want. I promise we don't bite, but we'll briefly answer a few questions up here. And if you have a question, feel free to raise your hand.
Awesome, thanks Bonnie. Thank you all so much for being here. I'll just start by talking a little bit about the tables that we had outside. Circle Care Center was here tabling. They're a really wonderful center that provides compassionate and inclusive care for their patients in Norwalk and Glastonbury. So we're really, really happy that they were here today. Kailey is here from Hello Endo Collective, so we'll hear a little bit more about that in a moment. I'll also introduce myself. I'm Billie. I'm a campaign lead for Tight-Lipped in Connecticut, and we're a grassroots organization formed by people with vulvovaginal and pelvic pain. Bonnie's a member, and so it's really wonderful to be able to share the film with all of you. I'll just introduce Bonnie. You all know our wonderful filmmaker. She wrote Lady Parts, which is based on her own true story. She co-owns Brain Room, which is a boutique finishing house in New York City where she partners with filmmakers to shape their stories. And she's a patient advocate as well. Christine Meche is a certified nurse-midwife with New Vance Health, who focuses on vulvovaginal pain disorders, pelvic pain, trauma-informed care, and conditions of hypermobility like Ehlers-Danlos syndrome. Kailey Mitchell is the founder of Hello Endo Collective, which was also one of the tables that we had outside. She focuses on raising awareness and building community for people living with endometriosis. So I'm going to ask a few questions. First of all, Bonnie, I would love to ask you, what was the reasoning behind making this story into a narrative feature film instead of a documentary? And did you always plan on it being a comedy?
Yeah, I think a lot of people actually are surprised when they come in and see the film. They think it's going to be a documentary, and it's not. It's a comedy film. And for me, comedy is like how I cope with things, and it just seemed like the natural thing to do. But when I was really thinking about it, I was like, okay, I could like stand up here and spit facts at you all day, and you might not listen or care. But if you're watching a story unfold where it's like the issue is humanized, and you suddenly start to see like, oh, this is a person. This could be me, this could be my friend, this could be my partner, I know this person. And you start to understand how this condition can like affect every aspect of someone's life and how isolating it can be, then suddenly you start to care. And so it was always meant to be a comedy film from the start, and comedy is just a nice, easy, digestible way to kind of get people's toes in the water with a conversation and a topic that can sometimes be so uncomfortable.
Really interesting. Thank you so much. And I wanted to ask our other patient advocate, Kailey, why is it so important to see patients' stories on screen or in the media? And what do you, wish people would understand about this perspective from the patient's perspective?
Yeah, that's a great question. I think it's super important that we have more people telling their stories, because a lot of times, when you're a patient living with one of these conditions, you go through years typically of being dismissed, misdiagnosed, navigating pain and chronic illness and everything that comes with that, right? So seeing a film like this to a patient can be the first time that they realize I'm not alone. It's not just me. And that's very powerful in the patient journey. Like having representation, like a film like we just saw, provides validation that you don't really see often in the medical field.
Thank you. And switching gears over into kind of the medical perspective, it seems like Paige really struggled to find a diagnosis even after seeing multiple providers, which I know is something that kind of all of us as patients have experienced. Christine, what are the biggest barriers to getting these conditions recognized earlier? And what symptoms do patients often dismiss that should actually prompt them to seek care?
Thanks, Billie. That's a great question too. So I think there's two big categories of barriers probably. One is patient barriers to care, whether it be stigma or shame associated with bringing up this concern to their providers. Or as we saw in the movie, there's other barriers to care. There's geographical barriers, there's financial barriers, especially for this area of medicine that is so overlooked. Finding people who are specialized can be few and far between. And so in the movie, she traveled across the country. She had to ask her parents for financial assistance. This is reality for a lot of people, facing these same kinds of disorders. It's not an exaggeration. And then I think the other side is the provider side and the knowledge gaps in care. Speaking for myself, in nurse practitioner school, I learned obstetrics, I learned gynecology. I did not learn vulvovaginal disorders. I did not learn vulvodermatology. I did not learn chronic pain conditions. That was all education that I had to seek out outside of my schooling, which I did because it was important to me, because I was a patient first myself. And it's something that I think, considering the vastness or the number of people out there affected, it should be part of, I think part of the curriculum, right? It should be part of our training and our education, but at this point it's not. And I think that was also depicted in the movie. We saw, how many providers she saw before she actually got an answer. And there was a second part to your question.
Let me see if I remember it. Kind of what symptoms should kind of raise a red flag for patients?
Yeah. Absolutely pain, for sure. It's not normal, no matter what. If there's pain, there's a problem, and it should be addressed. And I think it's okay for a provider to say that they don't know the answer, but it's not okay for them to say that it's not real or it's not there, just because they don't know the answer. And so I know that being told that it's not real or not there can make it hard for the patient to get back out there and keep trying to find a solution, but I would say not ignoring your experience is first and foremost. And also, one thing that we teach our patients is breast self-awareness. That's like pretty common, but we don't teach vulvar self-awareness. And I think that for patients to be the best advocate for themselves, knowing what is going on down there for yourself can be really helpful. I tell my patients, skin is skin. So what can happen to your skin, anywhere else in your body can happen to the skin of the vulva, whether it's cancer, whether it's, a growth, itching, rashes, whatever it is, can happen down there too. And it gets overlooked a lot of times because the dermatologist expect the gynecologist to take care of it, and the gynecologist expect the dermatologist to take care of it. So there's this like in between specialties, and it just kind of like falls by the wayside. But if patients are looking at their vulvas themselves and paying attention to any changes that look different, that's something they should be bringing up with their providers. And that's not to let providers off the hook. We should be doing our job to look as well, but you know, we have to be our own advocates.
That's great, thank you. And as Christine talked a little bit about the lack of education on this, I'm wondering, Bonnie and Kailey, as patient advocates, what changes in medical training or healthcare systems in general would you like to see to help, to better help clinicians identify and treat vulvovaginal and pelvic pain disorders?
I'll take it from a systems side. I like this question. So, in terms of a systems, I would love to see something you just mentioned on as well, more collaboration between specialties. I think that is an area that needs to be worked on tenfold. Because when you have a chronic pelvic pain condition, you're going to an OBGYN maybe, a urogyn, dermatologist, rheumatologist, and the list goes on, right? And you get bounced around, and as the patient, the emotional toll that we go through is significant in that regard. And you have to become your own advocate, and it kind of falls on the patient from my experience, to manage all the different specialties, and that's a full-time job in itself, when we're already living our lives.
I agree with everything you've just said, and same with Christine. As you mentioned, I thought it was really great how you said that, like, there's a huge gap right now in education, especially for residents, and there is this weird in between where, we're going to multiple specialists and stuff like that. And so even if you go to a doctor, I'd love for more of a trauma-informed care approach too, where it's not just dismissed, but, instead it's like, maybe I don't know what's happening, but let's work together to figure it out. Instead of this like, well, it's just in your head, or go see this person I don't know. I would love to see it more as like a team coming and approaching something together.
Yeah, I really like what you brought up about the trauma-informed care. And I was wondering, Christine, if you could speak a little bit about, for patients who have experienced medical trauma or sexual trauma, what can providers do to create a safer and more empowering experience for patients?
Well, I'll talk to you about what I do with my own practice. And first, I just assume that everybody has gone through trauma, right? Because we don't know who's gone through trauma. And even though on our intake form, it might ask if somebody's experienced trauma, a patient might not feel comfortable disclosing, or even if they do disclose, generally, they might not want to talk about the details. And so everybody deserves the trauma-informed approach. For me, I always meet my patients fully clothed. That's the first thing. Anybody who's new who comes to the office, the majority of the conversation is fully clothed, and at the very end, I will offer an exam, and if they choose to accept it, then I will step out for them to get undressed as much as they need to, and we can continue with the exam. But I think that people are most comfortable when they are fully clothed, and I want them to have a safe space to share their story with me. And so I think that's important. And then everything is an offer. I never tell my patient what I'm going to do to them. I tell them what I can offer them. And I will walk through the exam, the components of the exam, explain everything that I would offer to do, and then I ask them, is there any part of this exam that you don't want to do today? And that puts the power back in their hands. It gives them choice, and it, would say that most of the time patients want to continue, but there are certain times where patients are like, I'm not ready today, I need to come back, or I don't know when I'll be ready, but you know, this is as much as I can do today, and that's totally fine. They have the autonomy to do that, and as they should. If a patient wants to continue with an exam, again, I continue to verbalize everything I'm doing as I'm going, so nothing's a surprise to them, and I tell them that if at any time they need me to pause or stop, they should just let me know and I will listen to them. And if they do let me know, I do listen and I stop. And sometimes the patient doesn't verbalize that they need a break, but their body tells me that they need a break, and I listen to that too, because consent without assent is not consent. And I think those are the main things. Language also is really important. I think the language that we use, which is why I say I offer rather than I do, because again, it just puts the autonomy back to the patient. It gives them the choice. It allows them to collaborate with me on the exam, and hopefully makes them feel like they're an active participant rather than just, you know, having something happen to them.
Thank you so much. To finish off our little panel, I would love if each of you could just share quickly in like a few sentences what you wish all OBGYNs or other GYN providers understood about vulvovaginal and pelvic pain. I'll start.
I guess just like a amalgamation of kind of everything we've said here. Like, I wish I could just kind of summarize it down to a couple sentences. There's so much, but just knowing that, you know, when we come in, there's a power dynamic there, and we're always told, you know, trust your doctors, and, you know, we're coming in and we want to trust you, and we want this to be a partnership and teamwork, and, you know, we don't want to be in pain, and we're confused, and we don't know what's happening with our own bodies, and we're not taught about our own bodies. And I just really hope that, you know, as OBGYN residency education and more specialties are getting education, that trauma-informed care and understanding specifically vulvovaginal pelvic pain conditions and stuff like that is just common practice, and someone will watch this movie 10 years from now and go, why was that even had to happen? That's crazy.
I would say that I wish more OBGYNs would be more understanding, and just recognize that a lot of times when we as a patient come to them, we're not coming just to treat one symptom. We are coming to treat years, typically, of you know, not being believed, navigating pain, and just more understanding, like listening fully to us as patients. You know, I thought everything that you mentioned was great. Just listening and being there and just trying to understand, you know, what we go through on a patient level.
A couple of things really simply. I wish the whole OBGYN and advanced provider group knew that pain was not normal, that all pain is not infection. I wish that more providers knew that it was okay to say to a patient that they don't know the answer, but that they would go on the journey with them to find the answer. As much education and training that I've done in this area of medicine, there's still so much that we're still learning. And I think that I have many patients who I don't have an answer for them on day one, and maybe not on day 100 either. But I have things that we can try. I have people I can refer to. Like, I have tools in my toolbox and tools that I can give to them. And so I think the most important thing is just offering hope. And sometimes, like, I've never had a patient be upset with me saying, I don't know what the answer is, but I'm going to like help you figure it out. And this is not the last thing that we can try. This is not the last resort. There's more options. And I wish more people weren't afraid to have that honest dialogue with the patient. And the last thing, this might be more for insurance companies, but I wish that it was more, it was better understood that comprehensive history taking is so valuable, especially in cases like this. And unfortunately, insurance does not, and just hospital systems are not set up to allow us the time to do it well. And one thing I learned when I was in school was that when you have a complex case, or any case, and you go back and you look at the patient's story, the patient's narrative, not tests that were done, or imaging, or blood work, but you look at their story, the majority of the time you will see the answer in their words. Whether or not they come in saying they know the diagnosis, just in their story. And that tells me that we need to do more listening before anything. And so I wish that our medical system was set up to allow for the comprehensive history taking.
Thank you so much. That's really wonderful. I would love to open up to any questions that anyone in the audience has.
Yeah, I mean, and to further explore the insurance and systems, what really struck me was just how the procedure wasn't covered by insurance. Is there any work being done or advocacy being done to challenge health insurance companies for not seeing this as a cosmetic?
Yeah, I mean, it's a real huge issue. I think most, in tight-lipped, most of the patients and advocates have had paid like thousands of dollars out of pocket for treatment. A lot of specialists, especially in cities like New York City, just don't take insurance. And that, leads to the people that are able to access a diagnosis and treatment are the people that have that access to money, whether it's from their parents or, other sources. But I don't know if there's, specific advocacy going on in like the pelvic pain, vulvovaginal pain world related to insurance. But I do think a big push in that direction is to have it become a standard part of OB/GYN and, advanced practice provider training. Because if just you could go to your regular gynecologist who takes your insurance, and if they could treat these conditions, then this wouldn't really be an issue.
Yeah, no, I was gonna say same thing. A big point I always like to make when you're watching this film is that you're watching my story, which is a place of great privilege. You're watching a very, upper class white woman go through this system and struggle really hard, and you're just seeing my story. So it can go to show you, if someone that has the privilege I do really struggled to get help, you can imagine how bad this problem really goes and how deep it goes. And this surgery was in 2016, so that was about 10 years ago, and things have changed. Again, we have a long way to go, but I'm doing another vestibulectomy actually in June. Fun. I get to move back home with my parents again. It's gonna happen twice. Anyway, all that to say, I did find a doctor that does accept insurance because she did it under a hospital model. There's actually a couple doctors now that have found ways to get it into their curriculum, into their residency programs, and found ways to do it so that they could be in a system that could get it covered by insurance. So this next one I'm getting is going to be covered, which is incredible. But in order to do that, I have to literally fly to San Diego to get this surgery from Philadelphia. And it's actually cheaper for me to fly out to Philadelphia fly to San Diego with my parents, go get the surgery, stay in an Airbnb there for a couple days, and fly back and go back and forth for appointments than it would be to go to a provider closer to me, just because she accepts the insurance in the hospital model she's in right now. So there's progress, but there's still so much, I'm so privileged and lucky. My parents and I can fly to San Diego, and I can take off work and you know, I have the means to do that, and majority of people can't do that.
I don't know if this is still the case, but I think part of it is a coding issue. My experience was from a 2011, and at the time, the surgery was being coded as a miscellaneous procedure, and the reimbursement value was $250. Because they're not taking into account, how much time the procedure is requiring, that it's done under anesthesia, the skill of the surgeon involved, none of that. And I don't know what work is being done in that area at all, but to Bonnie's point, I think getting more providers trained who are working in an insurance model would be really valuable, because while working under an insurance model limits the time that you have to see your patients, and these other providers who aren't taking insurance, because they're not doing that, they can see you for an extended consult, a 60 or 90-minute consult, which is great, but again, it really limits how many people can see them. So more trained providers in the insurance model would definitely help.
Any other questions? Yeah.
Why do you have to get another surgery?
So 10 years ago, when they performed vestibulectomies, they took out pretty much the majority of the vestibule, but they left in the area right under the urethra. At the time, there was no skin to replace it. And so I've been like 90% better, which is huge when you've been living with like crazy burning, stabbing pain your whole life. You're like, oh wow, this is amazing. And so I didn't really realize until about a year or two ago that they've developed a new way to do it, where they're basically taking a buccal graft and using that to use as the skin down near the urethra. I'm calling it like a touch-up job at this point, but it's like, it's crazy to see just in 10 years how much has changed, and so I got everything done right 10 years ago. It's just now there's something available, and so I kind of had to sit with myself and say, okay, well, I deserve to be pain-free, and I deserve to, not have a burning, stinging pain near my urethra 24/7. So yeah, we're doing it in June, and apparently it's not as bad. We'll see. Stay tuned for Lady Parts Part 2.
Are we gonna get another film?
We'll see. We'll see.
Yeah.
So I'm curious, because I'm sure, given the fact that you're going to travel across the country and go through all of this, but you said that you are in New York, right? So is it similar to like endometriosis specialists, where you have to like really, do your due diligence, research them, make sure they have the qualifications that they need? So would you say that in this part of, New England, that there's no one that is specializing in this, or is that more like that's the best person that you found for you, just happens to be in San Diego? I'm just wondering about the access. Like, obviously we all know that the access to care is a huge issue, right? Financially, whatever those burdens may be. But is it just like finding that needle in the haystack, just like finding an endometriosis specialist is?
Yeah, and I'm sure Kailey can talk more to like finding endometriosis specialists too. And for us, there's definitely providers, but feeling comfortable, like how Christine mentioned, and like feeling that sense of like going in somewhere and trusting them with like the most vulnerable part of your body. There were some specialists I saw and I just did not feel comfortable. I did not get a good vibe, or I heard horror stories from other people. So I know that there's more providers out there, but it is far and few between because this education isn't there.
And that's very similar to the world of endometriosis, which I know there's many
It's overlapping.
many parallels.
It seems like that. Like I've had interviews with doctors in the other coasts as well, in other countries. So I just, it's amazing, not shocking, but.
Oh yeah. And there's actually new studies coming out that are linking endo and vestibulodynia, so that's really exciting. Well, not exciting, but like
Research is exciting.
Research is exciting, and there's a lot of ways that endo and vestibulodynia and all these chronic vulvovaginal pelvic pain conditions kind of work together. And so, yeah, if we can get specialists on board with all of them, yeah.
Yeah, and to find someone that takes insurance is a huge deal.
Huge.
Yeah, for endo and for vestibulodynia. Yeah, Chris.
So I know in the film you said your pain started at age 13. I'm soon going to be a family nurse practitioner and treating adolescents.
Congratulations.
Thank you. What would you recommend going about if a patient who's an adolescent comes in, but they're afraid, embarrassed, even tell their parents, and you might not have the resources to have surgery?
That's a great question. I think, just speaking from a patient side of things, obviously I didn't go to medical school, I have no medical background, but, I think when I went into the doctor as a kid and someone had I didn't know that tampons were not supposed to be painful, I just thought that that was just the experience, and I think if my provider had just asked, oh, how's tampon insertion, is it painful? I might have just said, yeah, you know what it is, and we could have kind of started that journey really early on. And, maybe they can't afford surgery, but there's other things you can try. And like Christine mentioned, just being that partner for them and letting them know that you're not going to give up on them and you're going to keep being there for that person. I can't imagine at 13 if my doctors had treated me like that. This movie wouldn't have had to maybe happen.
This might sound like I don't need to say this, but I wouldn't do a speculum exam on a 13-year-old.
Yeah.
Even if they were complaining of pelvic pain, because that's not necessary.
Oh, could you say that again?
We can't hear
Yeah, I wouldn't do a speculum exam on a 13-year-old patient, or even, I wouldn't do a speculum exam on anybody who's under 21, unless it was absolutely indicated, and in most cases it wouldn't be.
Yeah, you have an excellent point though, and I think, one of the main barriers is our medical construct, right, and our whole approach to pain. And it really doesn't start at the OBGYN office. It really should start with education across the board for all, not only residents, but nurse practitioners, nurses, and awareness of this condition. Because truthfully, it starts at the pediatrician's office. The whole tampon issue should be the first sign, right, that there is a potential problem. There are others along the way in terms of symptom presentation that pediatricians can pick up on. And we really have to train fundamentally. We have to really arm the army, people at the front line, right? Everybody who's working with adolescents and young women. And not waiting for a patient to present themselves with a condition. That's a terrible approach, and I'm sorry. I think patients come from very, affluent backgrounds who have that ability to navigate. It's fine, but for the majority of patients, they're going to get lost. And we really have to educate providers about these very early signs, and not expect patients to come in with the diagnosis.
No, I completely agree with you, and while I don't typically see adolescents, I will see as young as 13, but I don't get many of them in my office. I think the same is true for adults. I think that it is the provider's responsibility to ask the questions. I ask my patients if sex is painful. I ask them, about if they tell me that it is. I ask them, is it deep inside? Is it at the entrance? I ask them if they're able to have an orgasm. I ask them if they're able to have an orgasm alone or with a partner. Those different, some people will they'll check a box saying yes or no, right? But sometimes you have to dig a little bit further to get to the root of the problem, and I do think that's important.
And I think what's frustrating is that what you do is it's amazing, right? In whatever period of time that it takes you to do this, but in the day-to-day practice, right, with the way this construct of how we need to practice now, that's never happens, right? It's an in and out, it's sort of, and we have to change that fundamentally. We're never gonna address this issue. We
I'm
can't
doing my
expect.
best.
Yeah.
What is that?
I'm doing my best.
Yeah, no, you are individually, but it has to be at a fundamental level for everyone to be approached.
Yeah, but we have to get providers, we have to train providers better
Yeah.
to start.
And something also that I think I've learned is, you don't necessarily have to address everything in one appointment. So if you're able to ask, like, is sex comfortable for you? And if they share, oh, it's just, there's something going on, and, you can get that ball rolling, start having that conversation and say, look, we don't quite have the time to do a full exam right now. Or, we have to do these other things, and maybe could we have you come back in a few weeks, or, something like that, where even if it's a very short appointment, being able to have that like continuity, and over time, hopefully addressing those issues.
And I just wanted to mention really quick too, with the endometriosis working group here in Connecticut, we are working to try to push for education and policy change as well. So the steps are being put into motion, so that, could give us a little bit of hope.
Yeah, and there's a lot of overlap with endometriosis, and if it can be identified in adolescence, that's a huge improvement in patient outcomes. And, just being able to recognize, like really painful periods are not normal. And then, having that be kind of a red flag of there's probably something else going on here. So I wish that, similarly, being able to recognize, you started to try to use a tampon and that was really painful. Like, let's explore that a little bit more. So it kind of goes hand in hand with any sort of pain condition.
Yeah, there's a lot of overlap. That was actually like one of my first symptoms too.
Yeah, it's incredibly common. It's quite frustrating that it's not a standard part of education. We're working on it.
I want to make one other point, like completely agreeing with everything that everyone is saying in this room. What I'm seeing is, you just said that you don't think anyone should have an exam with a speculum until, they're older or perhaps after they're sexually active. But part of the problem is that like pediatrics aren't being taught to examine or question female genitalia, right? So if you get your period at 11, 12, 13, 14, but no one's taking you to see a gynecologist, who are you as a child supposed to go to when you can't insert your tampon and it's painful? Because we saw like the mother standing there trying to explain it to her, right? But it took her so many more years to get that. So my whole thing is like, we need providers that are actually in the space working in OB/GYN and in pediatrics to like stand up and say, children, women, girls deserve this care, and what are we providing for young girls in terms of teaching them their anatomy, but then also where are you supposed to take your 12-year-old when she says like, Mom, I can't put a tampon in. So I would love to see the institutions like Yale and UConn and all these big medical institutions like stand up and actually push for the change for that to go into medical teaching, because we've got all these great institutions, but I'm not hearing anything from them about endometriosis, pelvic pain, vulvodynia, or anything. So.
Yeah, I mean, I think something you're touching on is the way that, unfortunately, a lot of the exams and processes that you have to go through in order to, make a diagnosis, or whether it's an adult or someone, a pediatric patient, those exams can be quite uncomfortable and even very, very painful for someone with a condition like vulvodynia. You're always weighing that, like, am I doing more harm than good by putting this patient through a painful exam? And then I'm sure when it comes to pediatric patients, how do you balance trauma and causing, sexual trauma at a very young age, but also wanting to address pain and be able, so I think it's a constant kind of back and forth on how do we go about that?
Well, lack of
Yeah.
pediatric gynecologists, I mean, there's only 2 in the state of Connecticut.
That's
So
crazy.
even if you're a pediatrician, like, who are you supposed to send them to, you know, just even have that conversation, because I don't even think most girls even understand what their anatomy is. Like, there are grown women that don't know how to identify their anatomy because
Right.
they were never taught.
Yeah, Dr. Narcom?
Yeah.
I would just say, again, training the pediatrician, it starts at the pediatrician's office, who then educates the mother, right? I mean, it's just all of this process, and then from there, you don't, you know, you refer to any most gynecologists we see pediatric patients, right, if they're referred to us. But they'll never get to us because we don't talk about it. It never would happen in a pediatric office. I mean, I raised 2 children, it's never come up ever, as a parent, just witnessing, ever.
Maybe I'm
overbearing. Again, the construct of medicine, these 20-minute visits, these well visits, vaccines, updates, et cetera. Nothing ever comes up about pain.
It's true.
And I think it's just making everybody aware that this is an entity. It should happen at the medical school level. Just educate it.
Yeah. I think if it was standard for pediatricians to ask about pain, whether it's pain with tampon use, pain sitting, wearing tight pants, riding a bike, things like that, and kind of pairing that with like how bad are your periods, and kind of getting a sense of just whether your patient is experiencing pain. Yeah.
I actually had a lot of bladder issues when I was 5 or 6, and we went to the Top Chop Hospital in Pennsylvania. And I remember, I mean, I didn't have to remember, we found the medical records actually pretty recently. And it just kept saying, couldn't void. And like, and then it just said eventually like, well, it kind of went away. And that was it. There was no question, there was no nothing. And again, I'm privileged, I'm going to CHOP, I'm going to like this top urologist, and there was no red flags. And it never was brought up again. So there's so many little indicators. I mean, when you're talking about endo and vulvodynia and all these conditions, there's so many overlapping specialties. And so it's like flagging, are there GI issues? Are there bladder issues? Are there pelvic pain issues? Like there's so many different things that could have been flagged and could have not stopped, but could have just gotten to a path sooner.
Yeah.
Can I just off topic a little bit, but I'm starstruck being in the same room as a filmmaker. And can you just talk a little bit about like making the movie, who the actors were, what it was like to get them into that, the headspace of this topic?
Oh yeah, it was a wild time. This has been 10 years in the making. It's completely self-financed and self-produced. And basically, when we were making this film, we got very lucky with the cast and the crew that we got, because everybody was so on board with wanting to make this and passionate about what it stood for. The director actually also has vaginismus. So we originally met by talking about like our dilators and which dilators we were buying. And so that's what kind of sprung the conversation. Our editor mentioned she has endometriosis. She ended up getting a surgery. That's what kind of bonded us too. And so I think, and the more we kind of got on set and started to talk about it, the more people suddenly just started talking about it. We had our sound team who, one of the first days we were shooting that dilator montage you see with the lube, and they're like, I've never touched a lube before. We're like, come touch it. And then, what is this dilator? And then someone else was like, I dated someone with vaginismus. I know what this is. So we just kind of started to realize, like, on set, like the more open we were, the more open everybody else got, and how common these kind of things are. And, I'm really lucky. I was also like the producer on set. At one point, I was driving the truck every day with the equipment as well, and parallel parking it every day. It's crazy. And I remember specifically when it came to anything revolving around the surgery and stuff, Valentina is an incredible actress. She plays Paige. The parents are incredible. Everyone that played them they just did a fantastic job. They had such great chemistry. And when we did casting, it was actually in 2021 during the pandemic, so it was all over Zoom. Wow. the main character and the director actually did a short film together prior to this, and that's how they knew Valentina and brought her in and had her try out. And yeah, we really did like a full open casting call, and we got so lucky with the people that we were able to find. And from there, when we were on set, it was always just like a fun adventure. Like no one had used a sitz bath before, so I was like coming in, I was like, okay, so this is how it would look like. And because it's like, well, what does it feel like? You know, what would that be? Or, you know, when we're talking about the surgery and walking, like how would you walk with something like this? Because, you know, you can tell someone you shuffle, but that can mean like 20 different things. So it was a really cool experience getting to like be there on set and watch like everybody else kind of put their own creative input into it too, and their own experiences and stuff like that. And then getting to be there to kind of educate too. It was a really cool experience.
I just loved the dilator parts. I think it's so genius because dilators are like they're medical tools, but they're also just so comical that we're like, it's so ridiculous that we're being told to like use these, and they like the spectrum of sizes. And, like it's
colors.
just exactly. Love those intimate rose dilators. That's amazing. Any other questions? I know it's getting late.
Yeah, I was gonna say.
Yeah, do you wanna?
Yeah, we have like 2 raffles. Thank you, Kailey and Hello Endo, because we have an amazing raffle from them. And then we also have a Kiwi by the Pelvic People, if you've ever heard of that. So you got a bracelet when you walked in. Pull it out right now. Hopefully somebody got one of the winning ones. If not, I will just list some, and hopefully we get ourselves a winner. Does anyone by chance have the one that says "Read my lips"? No.
I think so. I don't know. Let me check. Read my lips.
You did! We have a winner! And then for the second one. Okay.
Put it on yet. That's
Oh, yeah. Congratulations.
Thank you.
Okay.
There you go.
Does anyone have the bracelet
So cute. Things to give to my granddaughter.
that says penis flytrap?
What is it?
Penis fly
Oh my God. Oh, that's so funny.
Yeah? Amazing. Yeah. Real quick before, obviously, all the people that you heard about tabling will be outside if you're looking for resources. I just want to thank Keegan and the Flint Street Theater for hosting us. This is an amazing space. They're looking for donations. They have free period products in their bathrooms here, so if you have any tampons, pads, panty liners, anything of the sort, please make sure to drop it off here and donate some. Also, Lady Parts is now available on Amazon Prime and YouTube Movies. So please go rent or buy us, and if you have 5 minutes, please leave us a review on Amazon, Letterboxd, Rotten Tomatoes. Tell your friends. It really, really helps. And I just want to thank Billie for moderating. Thank you, Kailey and Christine, for being here, being on this panel. You guys are doing amazing work. And thank you all for showing up here on a Monday night, and Jillian as well. Thank you. And we'll be around if you have any questions.
She'll get it.